You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Dr. Frumberg, welcome to the Nailed It Ortho Podcast. So happy to have you on. Welcome to the podcast.
Hey, nice to be here, especially talking about such a crazy topic as this.
You know, this is a fun topic because, we did a lot of, I think I was telling you this briefly before we started here, we did like a lot of non-union repair and where I went to residency, we had a lot of high-level trauma, gunshots and things of that sort where patients come in missing a lot of bones. So we had to deal with bone defects a lot. So anybody like doing, major at a level 1 trauma center or, dealing with non-unions and things of that sort, I think this is a useful talk to have.
Yeah, I mean, it also happens when you least expect it. I remember in training, there was a case where it was just a simple carpal tunnel that got infected and ended up with like this radius osteomyelitis. It was insane and had a bone defect that needed treatment. But of course, obviously the upper limb just tends to do better than the lower limb. But in the lower limb, there are some pretty unique treatment challenges. But I mean, it really shows up all over the place. And hopefully we can keep this conversation more high yield, but we could really get into the weeds if we drift too far. So we got to keep it honest.
Yeah. We'll stay on track. We may dip into the weeds here and there, but then we'll get back on track. But just starting off, we always ask our guests just a couple questions to get to know them a little bit better. I guess one question, is more interesting is what brought you into this kind of field of like, limb deformity, kind of this kind of practice that you have. You have a very, very specific type of practice right now.
Yeah, when I was a student, I really loved tumors. I thought it was really cool to reconstruct these huge defects and kind of avoid amputation. Maybe it was an inflection point, maybe not. I'm not quite sure. But when I was doing my sub-Is, one of the places I rotated was Newark, and there was a guy there, Dr. Benevenia, and I just watched him basically sculpt this person's limb without anything in it and put this mega prosthesis in. I thought it was the craziest thing in the world. So the idea that you could have this crazy huge case where maybe amputation makes the most sense, but do all this work and try to have someone keep a functional limb, not just like an appendage attached to their body, but an actual functional limb that they can use. That was just really rewarding. And then the concept of using external fixation, when I saw the first circular external fixator, was when I was a PGY4, just whimsically went to a training course on a weekend and learned how to put a frame on, and I was just in love. So that was kind of it. And then the idea that you could reconstruct a defect with someone's own tissue, really using biology and like doing it all, you're like creating bone. That was wild to me. So my mind was blown, and that was how I ended up in this kind of random field, this little niche field of limb lengthening and reconstruction.
Yeah, well, I mean, great story, and I'll tell you, there are always a lot of interesting cases, that come about from dealing with patients that have these bone defects. I thought it was super interesting stuff when I did it, or when I had those cases when I was in residency. Now I don't do
sports
much bone
fellowship when you guys are just taking care of all the defects and stuff,
right? And transitioning forth, another question we have is, we always have a lot of interest in the field of orthopedics, but any interest that you have outside of the field of orthopedics, it can be anything from fly fishing to golf or whatever it may be.
Well, I have 3 little boys, and that
Nice.
dominates my time, but we try to get outside as much as possible. Did some of my training in Colorado, so obviously got a lot of outdoors there. But now we're living in Connecticut, which offers quite a bit of outdoorsy stuff. So tons of hiking, tons of rock climbing, a lot of stuff here. The mountains aren't as high, but surfing, play a lot of music, try to keep busy.
Nice. Yeah, I remember I went to Colorado to visit one of my co-residents one time. And I wasn't used to the high altitude. And I remember I was just walking up some steps just out of breath. And I'm like, why am I so out of breath walking up some simple steps?
It hits you at 3 p.m. We still in this house, we call it getting threed. It's like just at 3 p.m. you just pass out on the couch. You don't really remember doing it.
No, I love it. I love it. Well, great. Well, let's go ahead and switch and kind of transition into the talk of the day. We're going to talk a little bit about some bone defects. And I guess just if we're just trying to build from the ground up, what what necessarily is a bone defect, and when do we see them? We mentioned a little bit earlier about trauma. What are some when do we see patients that have these different bone defects?
Yeah, bone defect, I guess you can classify it if you want. I mean, one of the people like to say a bone defect is whatever gap between two viable bones where, is beyond the osteocyte jumping distance, which is a term that people like to throw around when reductions aren't so anatomic, maybe in your Monday morning conference or something like that as they review all your weekend cases. But if you think that something will not heal, bone, two ends of a bone or two fragments, two segments, two fracture ends are not apposed to the point where they will not heal, they will not form callus and heal, then there's a defect in the middle. Something will fill that defect, but if it is not bone tissue and you're trying to create one bone instead of two separate bones in the long term, then that is a defect. So some people like to say a centimeter gap won't heal. I would argue probably less than a centimeter is pretty tricky in most situations to get to heal. But then also if half your cortical diameter is missing, so a defect could be partial, it could be complete. You may have had a butterfly fragment in an open fracture that was contaminated that you removed, but maybe you have one apposed cortex, like let's say the medial cortex on a comminuted femoral shaft, and you remove the whole lateral butterfly fragment. There's a defect there. I mean, it's a contiguous fracture, but you're missing a piece of bone. And how you treat that may be a little bit different from, the teenager who had 16 centimeters of his tibia removed or femur removed from osteosarcoma. So there are different reasons to have a bone defect. You could have an infected tibial nail that infects an entire tibia and kills most of it. And so are you going to keep that tibia? How are you going to reconstruct it? You have a big defect there. So there's a lot of different types of patients you see, and the patient matters just as much as the amount of bone that's missing.
Yeah, I'd say in my very, very, very limited career, I've seen the times I've seen this as being like due to trauma or due to just like you were saying, like an infection or something of that sort, where you're going and cleaning up tissue and removing infected bone. And when you look there and you see there's a huge gap, and then you're like, okay, how do we get this bone to heal?
I mean, you
And
mentioned non-unions.
yeah,
Non-unions are classic. You'll be in practice soon enough, but I'm sure down in Tulane you saw tons of non-unions that were operated on numerous times, and every
oh
time
yeah,
maybe whittled away a little bit of bone, or if it was a closed nail exchange, let's say for a tibia non-union, shaft non-union, maybe just the compression of the nail has kind of gotten rid of some length, or there's been some resorption at the non-union site. So you can get defects there too, even if you're not treating it as a defect, but you certainly could get a defect there. So it's ridiculously common to have defects.
yeah. I think I was telling you beforehand. One of our trauma surgeons in residency kind of developed this kind of non-union practice where he deal in fixing a lot of these patients that had these non-unions. So we definitely got to see a lot of the stuff that we're going to talk about today, like the bone transport and Masquelet and all these different ways to try to get bone to heal. And one of the things with that you mentioned a little bit earlier was kind of classification of these different bone defects. What are some different ways, or how should we think about, because this classification, at least in this paper that we read, is a good way to organize your thoughts on how you think of kind of bone defects. So what are some ways that we can begin to classify and think of these different defects?
Yeah, I actually love the paper, not only because the author is a friend of mine, but so Nando Ferreira, you'll give a link, obviously, in the show notes to
Yep.
people. Yeah, so it's a good, you don't have to really read every little detail, but there are some small tables in there, things that would help you think the way you should think, in my opinion. So first
Yeah.
is, what is the defect and why is it there? Is it massive? Is it small? How much biology do you need in the ideal situation to heal this defect? So if it's, let's say, God forbid, like a 6-year-old kid who's missing a couple centimeters of tibia, maybe you have intact periosteum. You could just throw some bone graft in there and the kid will just heal it. That would never, ever in a million years work in a different patient. So the next thing you have to think about is what is covering this defect, if anything. Is there a soft tissue defect? Is the soft tissue perfect? Is the soft tissue not reconstructible? Is this patient so sick that they will never be a free flap candidate? and therefore going down this reconstructive path is just a waste of time? Or are they perfect and have excellent vessels and no peripheral disease and no diabetes, things like that, and you can do whatever you want and they'll heal it? So there's usually you're somewhere in between. So bone defect, then soft tissues, and then the host type. And it's funny because he talks about type A, type B, type C. So a type A host would be someone with a perfect immune system or a good enough immune system, good delivery. Whereas a type B host would be someone who has a locally compromised or systemic immune system ability to heal things. And a type C is someone that you shouldn't treat because I'm sorry, that's someone with minimal disability and the treatment is worse than the disease. So they're not a surgical candidate. So it's like I would always laugh at this and say, have I ever met a type C host? As a
Right.
surgeon, you can probably operate on everybody. But
Right.
when you think about what the burden of the treatment is versus the burden of the problem of not having a limb, it helps you put that into perspective. So there's a million things you could do. I mean, residency fellowship, you get tools, but when to deploy what tools on which people, that's the hard part. That's where the ABOS is making sure you know how to do.
Right. Yeah.
Um,
Yeah. Go ahead.
no, that's it.
No, I was gonna say, and I love this classification system because it makes you think of it makes you put together or kind of figure out the overall like clinical picture of putting all these different things together of how you're going to treat this patient, kind of what necessarily are we looking at, like you mentioned the bone defects. Is it just a small defect or is it a large defect? You mentioned
Yep.
the soft tissue type. Is it just something where there's no soft tissue, or something that's going to require some type of plastic, consult to start looking at, oh, are we going to need some type of flap coverage? And then you mentioned kind of that whole ladder of maybe the unreconstructible part of it. And
Yeah.
now one of the things in this paper, or just kind of reading on this, we're looking at kind of negative pressure wound therapy or wound vacs. What's the role of that in the overall scheme of things when we're looking at kind of soft tissues?
Yeah, I will say, by the way, that it's important to know wherever you end up or whatever situation you're in, what your plastic surgeon availability is. So, I mean, we're very fortunate where I work to have plastic surgeon who is just always available, has block time. We call it orthoplastic block time. Like can just
Nice.
take a tibia and cover it within a number of days. That is very rare, and it's actually very difficult in the US to just have a plastic surgeon that's so available and have an OR that's willing to give them, I don't know, 7 hours to do like some crazy free flap. So it's tricky too, because then if you don't have the right plastics coverage, it kind of limits what you can do to the bones. Now, in an ideal situation, when I was training, we would just like throw a vac on everything and say we were good. Like, oh, there's a vac on there, and somehow magically it was sterile beneath it.
Right.
The truth is that vacs are not a substitution at all for really host soft tissue coverage. So it's nice to get granulation tissue. It's nice to try to stimulate a local healing environment, but you can't put a vac on a bone and expect something to work. You shouldn't put it on a tendon and expect that tendon to ever work. Same kind of concept, right? So if you can get some kind of coverage and put a vac on it, that may be good. That's certainly a time-dependent situation in a perfect host. But for vacs, they're just good kind of temporizing, but definitely not to maintain sterility like we believed when I was in training.
Yeah,
I
yeah,
know
yeah.
you're guilty of that too. I
Yeah,
know.
yeah, no, no, totally agree. I mean, yeah, we use wound vacs a lot, just to help kind of, just keep the wound, increase some of the granulation tissue and things of that
Yep.
sort. I remember there was actually a test. It was either a test question or it was maybe an ortho bullets or a res study question that asked us about negative pressure wound therapy. So they actually do ask questions about wound vacs for those that are listening to this. So definitely definitely read up on wound vacs.
Yeah, I
Um,
think the key though is when you take someone to the operating room and you end up putting a wound vac on, and that's different from an incisional vac, which is a different
Yep.
situation. A wound vac is to try to stimulate actual skin tissue to form, or at least a base where you can put a split thickness graft on. You just really, the second you put the vac on, you scrub out and everyone high fives. Your next phone call is to your plastic surgeon to say, guess what I got for you. Now there's a concept called the reconstructive ladder, and I'm sure everybody has kind of seen that, from local flaps to regional flaps to free flaps, and there's this whole cascade of different involvement that you could do. But nowadays we sort of believe in this reconstructive elevator, where like skip all the local stuff that may not work and just go straight to the free flap kind of thing. So if you have
Okay.
someone who is willing to do that stuff, it improves your success based on research for all these open injuries and badly infected injuries.
Yeah, I remember in residency we'd have to coordinate with the plastic, with the
It's the
plastic
worst.
surgeon to see when they're free and
Yeah, it was
when
horrible.
we're having training. Yeah, it was a lot
The
of
patients are just
coordinating.
going back to the OR like every 2 days to just
Yeah,
get
yeah,
some water sprinkled on them. But
yeah, yep,
magically
yep,
that was gonna, yeah. So I think the sooner you close it up, even if there's still persistent infection, we still believe that getting soft tissue coverage and getting them healing from that. And then where you go from there, by the way, that is still kind of up for debate. Some plastic surgeons make you wait a long time before you cut open their flap to do some bony work underneath. So let's say you had a bone defect from infection, maybe getting ahead of ourselves here, but um, you want to manage that dead space there. So we typically would put a spacer in and then something for stability. And then you'd have to wait however long they make you, until they believe their flap is mature enough, or maybe sometimes they wait till the blood supply is independent. But that could take a while. So we've
yep.
sort of gotten our time down to about 6 weeks now. Some people will do just 4 weeks, depending on the flap. But I mean, you can go back and do stuff along the way, but getting it covered and decreasing the consistent contamination and kind of allowing the vascularity to form, and kind of improving the angiogenic potential of the local area, that's very important.
And speaking of, so what are some of the different, you also mentioned, the host type. So kind of what's their overall picture, look like, are they a patient that has a low CD4 count, they don't have many neutrophils to fight off infections, things like that, because they're more likely to have an infection. So you mentioned the host type, but what are some of the different, I guess, treatment options that we have for addressing these different types of bone defects? I know
Yep.
you can kind of break it down many different ways. So I'll let you kind of break it down
Sure.
however you want to.
Yeah, I would just think of the number one thing for a host is, are they willing to put in the time? It's the psychosocial aspects of this of treatment of bone defects is probably the number one most important factor. So grit factor of the patient. But I will tell you, I've been dead wrong. Sometimes I'm like, man, this guy is not going to last. He's not going to make it through. Other times I'm just pleasantly surprised. Maybe I think it wouldn't be good for them for their social situation, and then it's perfect and they can reconstruct their limb. Some people, it's quite the opposite, or if they're in a frame for a real long time, they get what we like to call cage rage. So maybe they did their
Okay.
transport, they're just kind of waiting for everything to heal. They're not doing anything anymore. And it's just like, when can I get this thing off my leg? So that's the number one factor for me. And that is not in this classification system.
Yep.
And it won't be on your exam, but it's something to think about probably for every complicated treatment you offer, anyone listening that you offer any of your treatments, any of your patients. Grit factor is number one. And I'm not very good at predicting it, but with time. The
Yep.
second thing for me is their time. Are they willing to actually put in the time for this? Because that is the one resource that we can't get back, which is also the subject of my current research. So more
Yep.
on that some other time. But if I tell you, listen, you got like a 15 centimeter defect, it's going to take you 18 months. I'm just throwing that out there for whatever reason. Um, are you willing to have to go through this? That's a lot of time that you're not going to get back.
Yep.
And then some people genuinely are okay not having their limb. And so if they're not willing to do that, or they don't want to have some massive reconstruction and they're willing to lose a limb, amputation is definitely, we don't view it as a failure. It's just one of the other options that you can have. And what's exciting about 2024, when we're recording this, even though I know people are going to listen to this for years to come, but right now we have technology that's on the way and increasing in its availability, and acceptance, such as osseointegration and some other newer type prostheses. So osseointegration, for anyone who doesn't know, it's where you put an intramedullary, so you have an amputation. And then for some amputations, such as think of like the very short AKA, above knee amputation stump, it's really hard to wear a socket around a short bulbous stump. So for me, the classic person to do osseointegration implant would be that, a short AKA. But you could do it in many different scenarios. But the idea is that you have an intramedullary component that then exits the skin through an aperture, and you could just hook your prosthesis directly onto that. And it's a whole science behind it. And there's some centers that do it very well, kind of gaining acceptance, but we'll see what the future holds. But as we improve prosthetics and human prosthetic interfaces, then it's possible that people will opt for that, that maybe amputation is not as big of a deal. It's certainly not a failure. So that's another big thing. People who are protein malnourished seem to be the ones that give me the most worry. So that's one of the few labs that I look at. I mean, I'll look at their white count and make sure they can follow and fight an infection. But when I see protein malnourishment and low prealbumin levels, I really worry about that. I admittedly am not checking CD4 counts routinely,
Right.
but that is another thing that Nando highlights. So now, as far as actually treating defects, we have a lot of different options in our armamentarium. So I guess we can maybe I don't know how you want to go about this. The short defect.
Let's go. We can go from short to medium to I guess larger defects. And
okay.
we can
Short
talk about
defect, we're
different
thinking like
devices.
less than 2 centimeters.
Yeah.
So pretty small. A lot of times, especially in the upper limb, you can just graft that, and magically the body can heal it with secondary bone healing. So I don't know if you've ever seen a case like that where maybe you had an open radius shaft and you're missing a chunk of bone, or I don't know, something like on the ulna, and you just put autogenous graft in there and it just magically heals. It takes a while, but it can just heal, especially if it's aseptic. So that's one option that you have, probably in a type A, perfect host, small defect, good biology, upper limb, excellent biology. The other option you have is to just shorten it. You just take, like, especially in a radius, if you have a 1.5 centimeter defect in a radius and ulna, or even a humerus or tibia, whatever, you could just shorten it acutely, get nice, healthy bleeding bone ends and put them together, and then nail them or plate them, whatever, compress them, get them to heal. That is definitely an option. And one thing I always tell people is you can always get length later. Lengthening is something you could do at any time, any age. The youngest person ever lengthened was like 3 or 2 or something like that. The oldest person ever lengthened was in their 80s. So you can get length at any time. You don't get obsessed with length, So if you shorten it and that's not okay, you could always get length. Yes, it's another operation, but it's good to have that option rather than having a defect. So shortening is one option. Now, I will say shortening, we're jumping ahead a little bit, but if you have a slightly larger defect, shortening does not do well. So some people will say, 5 centimeters, you just shorten it acutely and plate it, get it to heal, and then you can go back. The truth is that it's a lot of soft tissue to manage. If you're listening, the best way I could explain this is if you took like a bag and just grabbed the 2 ends and pushed it together, or I don't know, maybe take like I'm trying to think of something like a balloon or something. You push the 2 ends together, it just folds in on the middle. And then you have all this tissue that doesn't know what to do. And you interrupt the lymphatics, and you get a lot of swelling, chronic swelling, and a lot of wound problems. So a lot of shortening is better done gradually with like a compression, either in a frame or in a nail or something that can compress it slowly. But shortening is not always the right answer. However, you can shorten and then lengthen either in the same treatment or in separate treatments.
Yeah.
The other options you have are, if you have a defect, you can use a technique called Masquelet, which probably is on a test, but the other name for this is an induced membrane technique. The idea being that your body sets up reactions to foreign objects. Anyone who's ever done an open plate removal, you can clearly see there's a little membrane that kind of forms along the implant. And so if you put in thing of cement, like a little piece of cement that fills the defect. Then you just wait. The body will react to that and set up we call it a membrane, a Masquelet membrane. And that is a very bioactive membrane. And Kevin Tetzworth is the surgeon who did tons of research on this that comes to mind when I think of Masquelet. But there are different phases of biological activity. And what you really want to do is get the membrane when it's most angiogenic. Because remember, this is a biologically dead zone. So you're trying to create biology. So there's a spike of angiogenesis, and it's different for every bone. So in the femur, it happens a lot sooner than it does in the tibia. But what you do is you wait until this membrane forms, usually a number of weeks. Then you can go back, open the membrane, cut it just like any other fascial plane, gently scoop out whatever spacer you have, whether it's beads or a solid block of cement, and then graft it and try to harness the angiogenic potential of the membrane to then ossify that graft and incorporate it. So the problem is it's just not realistic to wait so long. But in the tibia, sometimes you'll read that it's like 14 weeks is the perfect time. And that's just too long. And so a lot of times we're going back at like 6 weeks, 8 weeks, and you're not really harnessing the perfect potential of it. But a lot of people have kind of gone away from Masquelet depending on their training. It seems to still be very popular among the traumatology community. Yep. But it works for some people. For me, not so much. But, it probably has to do a lot more with the local biology. But Masquelet is definitely another, this induced membrane technique is definitely another option that you have.
Yeah, I remember they definitely asked questions about it, and we use this a bunch in residency as well, just exactly how you just described it, like putting a cement spacer in there and then coming back a certain amount of weeks afterward. One question I did have is, how do you determine how many weeks afterwards that you come back to do the second stage, where you remove the cement spacer that you placed into that bone void, and then you come back and you put some type of a bone graft in there to get that to heal? Well, how do you know when's a good time to do that?
A lot of times the spacer is going in at the time of free flap. And so it's usually determined because the plastic surgeon lets you go back at some time. But for me, I try to do it a little bit longer in a good host. That would be probably about 10 weeks for a femur, which is much longer than typical. I think typically people go back like 6 weeks or so, 4 to 6 weeks. I usually try to go a little longer. And then for the tibia, I try to get as close to 3 months as I can. But that is probably too long based on the general what everybody does. So if I can get there 8 to 10 weeks, I would say that's a sweet spot for me. But I have not had great success, so take that with a grain of salt.
And then on the second stage of that, the bone that you're putting back in, when you come back for your second stage, and you're hoping that this membrane has been formed around the cement spacer, and just like you said, you go in and size the fascia and just kind of create that plane and scoop the spacer out. How do you, I guess, maybe what are some different options for bone graft that you can put in there that you hope to heal? And then how do you decide in one versus another?
Yeah, I mean, it's certainly volume dependent, right? I mean, you can only get so much cancellous bone plus marrow with a reamer irrigator aspirator system. You can get some, if you have a very small defect, you can get some with, there are suction curette devices that you can use now, maybe get distal femur. The gold standard will always be iliac crest. And it's sort of like a lost art. I don't know, maybe like I'm a millennial. I don't know what you consider yourself to be, Wendell, but we don't really go iliac crest that much. I probably count on one hand how many times I've done it in practice.
Yeah.
But there's like this classic thing where it hurts everybody. So even though there was a paper that was presented at the OTA this year, that was a great study, and they showed that the chronic pain from RIA, so reamer irrigator aspirator, which is a intramedullary device that can harvest while irrigating and filter out all the contents that you're kind of suctioning out of the middle of the canal. That has the same amount of chronic pain, which is a pretty low rate, as iliac crest bone graft. And I believe that was a prospective randomized study. So that it was a really, really great study. So maybe we can go back to the crest a little bit more, or maybe you could look at that study and just say, we don't ever have to do that. We could just do a RIA. I mean, like the limb is already draped in. You might as well do a retrograde RIA. So it has its own downsides anyway. But I would say for me, when I need a lot of graft, I usually use Rhea, and I'll combine it with some, lab grown crap like dead guy bone or DBM or something like that. So there
Okay.
are all sorts of different trade stuff out there that you can add. But one of the biggest problems is this is a cylindrical defect, because you're usually doing it for a long bone in the lower limb, let's say. So
Yep.
a cylindrical defect, and you're going to walk upright. So the graft is going to be it's going to be subjected to gravity. And what we can see a lot of times, let's say the distal femur is a very common place to have a defect from a non-union, like a distal femur metaphyseal non-union.
Yep.
So if you just graft that after Masquelet, you will see that the graft will slide distally and then wither away proximally. That's a common phenomenon. There are some ways around it. There are some companies now that will make a 3D printed, patient-specific kind of resorbable graft cage that can capture
Okay.
the graft and give you a little bit of structure to prevent that graft creep. But that is a pretty big problem for the big defects. Getting in the weeds
Yeah.
now.
No, no, this is great. And just and please correct me if I'm wrong here, but for those that are listening that haven't seen the RIA before, just like you explained that reamer, irrigator, aspirator, that's where you kind of like, you make an incision like you're doing a starting point for nail, but you put a reamer in there and you ream the canal of the femur per se, and so you're getting all the medullary contents that are getting. You have suction and an aspirator hooked up to the back of the device that's suctioning and aspirating everything else out, and you use that bone graft and you put that bone graft into wherever, whatever void it may be. So that's kind of the whole RIA situation. Um, and so for the Masquelet, you were describing originally for kind of our type 1 defects or our defects up to 20 millimeters. How up to how many defects up to how many millimeters can this be used?
So it has been shown to be used massive defects. By massive, I mean more than 12 centimeters or more than 10 centimeters. So you can use, some people have had success with Masquelet with ridiculously long defects. And there are
Yep.
some things you could do. I mean, you can combine these methods too. So the other thing, we'll get into it when we talk about massive defects, but distraction-based techniques can be combined with Masquelet, which is pretty standard practice now, I would say. But you can
Let's do it.
do greater than 12 centimeters. You can easily, try a Masquelet and see if it works. I mean, like I said, if you fail, it's just time for the patient, which is a big deal. But one thing I think Masquelet does get, though, I think it gets something called an implant dependent union in a lot of cases. So obviously we know that if you just have a defect in your bone, why do you even have to treat it? Why not just put a nail? Like if you're missing the middle of your femoral shaft, why not just put a nail, get it out to length, and just live with it? And the reason is because if you bend a paperclip enough times, it's going to break. So you're going to
Yep.
get mechanical failure of the implant. But if you can get enough biology, which remember, bone is constantly remodeling and strengthening itself. If you can really get some biology in there that constantly strengthens itself and supports the implant, you can probably get an implant dependent union, meaning if you take the implant out, the femur will collapse, maybe. So I think in a lot of cases you get that. But again, that's my very biased opinion.
Yep.
Now, for me, massive defects, bone transport is the way to go. Now, bone segment transport is an awesome and very biologically predictable process. Excuse me. The idea here is that if you have a defect, and we know of this concept popularized by Ilizarov called distraction histogenesis, we can literally create tissue just by pulling on it for a really long time. So the idea is that you can cut the bone in a very low energy way. So convince the body that it has a minimally displaced, low energy fracture, and it tries to heal that just by standard secondary bone healing. If you're really good, I guess primary bone healing. But if you just make
Okay.
a quarter, Ilizarov talked about a corticotomy, just cutting the cortex, but maintaining the periosteal blood supply. Ilizarov also believed in the endosteal blood supply, but we know now from our techniques that involve intramedullary devices that maybe the endosteal blood supply is a little bit less important. Jonathan Schenecker taught us all in recent years that the pericytes are the stem cells that live underneath the periosteum, and those are the primary stem cells of bone healing. And so those are the ones that we really want to preserve. So if you do an osteotomy where you preserve the periosteum, you don't generate a lot of heat that would kill the parasites. So you do it with maybe an irrigated drill bit that's really sharp, and then either just crack it with your hand or send a very sharp osteotome across and maybe lever it even just to complete the crack. But you do something that creates an osteotomy in a very low energy way and maintains biology. You can then set up a healing response and then stretch that healing response into oblivion. So in this case, if you have a 10 centimeter defect in the middle of the femur, or let's say distal femur, you can cut the bone proximally, and the same concept of distraction can be applied to that osteotomy, and that bone segment can be moved into the defect to decrease the size of the defect while lengthening, quote unquote, through that osteotomy. So you're going to transport one segment of bone into the defect to minimize the defect while growing new bone above it. And it sounds awesome because it is, and it works.
Right. And you're able, I remember this is one of the things that when I was first studying a way long time ago, I didn't necessarily understand, but you're able to transport this bone because you have pins or you have something going through the bone and you have a device on the outside that's moving the bone daily. Is that right? Or can you kind of explain
Yeah, you
how that
can use
happens?
internal device, you can use external device, you can use combination of the two. There are a lot of different ways to affect the dynamic change. This limb lengthening and reconstruction world, when you put someone to sleep to take care of their sports problem, that's a static problem. That's a static fix, right?
Yeah.
You put them to sleep, you fix it, you wake them up. But for us, we put them to sleep and then we start moving stuff. And I think that's why I love this field. So you can either use an external fixator to hold the most proximal end and the most distal end of the bone together while you move all the stuff in the middle. You can do that with a plate to hold the bone in place while you move the stuff in the middle with an external device, or you can move the stuff in the middle with an intramedullary device like a lengthening nail. There used to be and there will be soon an all internal transport device that goes intramedullary. So there's a lot of different options. I mean, and then the limb lengthening reconstruction surgeons do really crazy stuff. Like I'll do an extramedullary nail with a plate to move the bone while holding it stable. I mean, like you could just put all these things together, but as long as you're not sacrificing biology and you're doing something to keep everything in alignment and fix the defect and there's a goal at the end, I mean, nothing's out of the box.
Yeah, yeah, man. And how do you, I guess one of the questions that I always had not issues with, but I was always thought about was how do you decide between, this distracting based treatment and, for example, Masquelet, if they both can be treated for large defects, is it more just kind of surgeon preference, or how do you decide between one or the other?
Yeah, I mean, so if it was all surgeon preference and we were super paternalistic, then everybody would have a circular frame and have bone transport if they came to see me. But the fact is, everyone has a different circumstance, or they have some biological reason not to have a frame or whatever. I'll give you a great example. A gentleman that I saw recently has a chronic osteomyelitis and deformed tibia, but unfortunately he's incarcerated. I can't send him back to jail with a frame on. So I'll
Right.
do his excision and correction, and then I'll put a spacer in around a nail, an antibiotic coated nail, and that'll be what he gets. And he could actually use his limb. I'll make him 50% weight bearing or whatever during that time. And then he'll come back, and ideally by then we can do his transport with an all internal device if he's infection free. That would not be my first plan, but the alternative is untenable for him. So it's nice to have all the different options. And then what you choose to marry to the patient is different.
And in your use of the internal fixation device or external, your use of internal versus external fixation devices, like you mentioned a couple of internal fixation devices like an inch measure, a nail construct,
Mhm.
or you can also, use a plate, or you can use an external fixator. Your choice is one versus the other. Is that surgeon preference, or is one better than the other in certain situations?
What?
This may be getting into the
Yeah.
weeds a little bit, but
Well, I think if you have an
just to talk
like
about
for
it.
me, if you have an infection, and we learn very early in our orthopedic training about biofilms, So if you have some kind of internal device and you have an infection, that's probably bad. So if you have an infected tibia, the best thing is to go into a circular frame, in my opinion, if you can.
Yeah.
Now I will say, like, the frames I put on when I first went into practice, pretty ugly by my standards now, you know. And I mean, I wouldn't call myself an expert, but I do a lot of them. And I think that if you're not doing it all the time, it could be a little bit challenging. But in our community, there's tons of support. I mean, I get emails all the time from people asking, is this a good option? Things like that. Or how would you do
Yeah.
this? Like my own partners, you know, we talk to each other, things like that. But so I think if you have the capability to do external fixations, it doesn't even have to be a circular frame. Everyone could do a pin to bar, and that may be good enough. You know, a delta frame with a pin in the metatarsal. The downside is that you can't walk on that. So if you can use the limb functionally, like putting a circular frame on, you can be fully weight bearing throughout the entire treatment. You can go to work. You can go climb rocks. Like, you can do tons of stuff. Go swimming. So I think there's a lot of differences between the treatments. There's a lot of benefits. But if you're comfortable, like Wendell, if you're comfortable putting in a tibial nail, maybe downsizing it a little bit and coating it with cement and putting that in the canal, do it. You know,
Yeah.
you're not doing anything wrong by the patient. You just have to do what you have to do to get the infection or whatever the source of the defect, fix that. So
Yeah, I did a lot of those in residency. Those are fun cases. A lot of the antibiotic coated nails. We use like a chest tube to get the antibiotic around it and cement and all that good stuff.
now we'll
Um,
say this though, there is this
yeah,
concept of conversion, which we haven't
okay.
touched on. So if you
Yeah, go
obviously
for it.
if you have this if you have a really bad host, like you have a B type host, and you can convert them to an A type host, then you do that. Off the top of my head, I can only think of one time that happened, and that was a guy with horrible peripheral vascular disease. So he got a fempop bypass in anticipation of a free flap, which was like crazy because it took forever, obviously, right? You got to wait till the bypass heals and then
Yep.
got to go back in. So that, I mean, we converted him from I guess he was a C type host because he was not a candidate for a free flap. We converted
Yeah.
him to a B type host. He actually did great, that guy. There's another guy coming up who has an upper limb defect who's going to have to get an AV anastomosis because he already had a failed free flap. So now he needs a new free flap, and then he's going to have to get a bone flap. So he needs like a new arterial venous anastomosis from the plastic surgeon that then has to mature, that then can be used to bring blood supply. Because I think he's going to get a free fibula, which is another treatment we didn't talk about. Free tissue, like
That
autologous
that
tissue
that's
transplant.
exact that you just transitioned yourself perfectly. That's exactly what I
Nice.
was about to ask you about next. So yeah, let's go ahead and hop into it.
Yeah.
When is the time to use that? I remember I think in residency one of the plastic surgeons was just like, you need to use a free fibula graft. And you're like, oh, okay, well, you know, why is this indicated? What do we need to use it for? So
For me, the
it could
free
let us know.
fibula is that's like my last resort. That's my ace in the hole. So I would try so many different things before using it, only because I know that I can use it. It's there. It's always my bailout. There are some downsides to using a fibula, but basically the idea is that you take the fibula, the center of it, right, the middle of it, and we all kind of know if you harvest just the middle and you leave the ankle intact, even without a synostosis between the tibia and the fibula distally, you can still have a stable ankle because most of your
Yep.
syndesmotic complex is distal. That is not as true in the young child. In the young child, they get this kind of like shortening of the fibula, maybe, but it leads to ankle valgus, maybe because there's no lateral strut from the defect in the fibula. Some kids actually will just heal it because the periosteum is still there. They just heal their fibula. It's the craziest thing in the world. But
Yep.
either way, you would take the fibula plus its artery plus its vein. You can actually take a paddle of skin with it too, which is nice. You could take muscle with it if you need it for additional coverage, but you can take that and plug it into the defect. You can combine it with a Masquelet. So maybe when you go back to graft, that is your graft, and you put that in there and you're getting parasites from the outside and you're getting blood supply from the inside. You can combine it with shortening. You can combine it with transport. I mean, like you could do any of these techniques for grafts, but the vascularized fibula is basically bringing a live, perfect tissue and putting it in a place where you don't have any. So you're bringing the best type of biology. And then the little skin paddle you take with it is nice because then your intern safe. You know, like you can go to sleep at night knowing that any intern can look at the little piece of skin and know that the perfusion is still perfect, right?
Yeah.
So the free fibula
Yeah.
is cool. There's a bunch of different ways to transfer it. I mean, you could transfer it gradually with distraction. You can have plastic surgeon open it wide and kind of sandwich it in between the two tibia pieces. I mean, the other thing is that it is a set size. So there's a couple of different ways to make it bigger. Like you can cut it longitudinally and try to splay it open and then graft addition to it. So there's a lot of nifty techniques. There's this other thing called the, what is it called? Capana, I believe, where you take
Okay.
a vascularized fibula, you put it inside an allograft femur. So you do that. So it gives you like a little bit more size and
Oh,
structure.
okay.
So then instead of putting like a chunk of dead guy bone in, which is what the musculoskeletal oncologists like to do, now you're doing it with vascularity. So it improves healing. So there's a lot of different stuff you could do.
Yeah, no, that's great. That's cool. That's to be able to, there's so many, I'm always amazed of how vast and wide and so many different options that you have of things that you can do in orthopedics. And even in this such niche field, there's like still so many options of even just one surgeon, one case that you can do, a million different ways to make something happen, make something heal.
Well, what's cool
And
is that
yeah,
technology is expanding like crazy.
yeah,
And
yeah,
the human body biology has not changed. We're just understanding it a little bit differently every year. And there are people who push the envelope, who are willing to share their thoughts and findings with the world. And, we're doing crazy stuff now that would never be imagined like 100 years ago, right?
yeah.
So,
Totally agree. And one of the things I wanted to just to quickly touch base on before we wrap up here is that earlier in the talk you mentioned amputation as one of the treatment options for these patients. And I remember during residency we've had a fair share, not a fair share, we've had some patients that again just prefer to just go with an amputation and have it be done instead of going through the multiple different surgeries. It's kind of a discussion that you have. But in your experience, I guess what are you leaning towards amputation versus trying to, salvage these bone defects and make them heal and this and that, etc.
yeah, I think a lot of it is patient preference, maybe when they're not fully informed, because I know that our ability to get an amputation these days that is more functional with things like targeted muscle reinnervation and whatever that other thing is where they wrap the muscle around the nerve. I don't
Yeah,
remember what it's
yeah,
called.
yeah. I know what you're talking about.
Yeah. So I mean, you could do better things for the stump to make the stump a little bit better. Phantom limb is still a concern, but we think we're getting better at it. And then socket interfaces are better. So the actual prostheses are better. The same plastic surgeon, believe it or not, who does our like free flaps. I mean, we have a team of plastic surgeons, and they're all very good also at doing these amputation flaps, just making sure that the TMRs are good and all that. But I mean, it's also helpful to have them meet amputees. If you think someone's a type C host, I've had people convince me to do transports on them, and they learn one way or another that it wasn't the right move.
Yeah,
So what's tricky about that, by the way, is that you need a certain amount of length on your tibia.
yeah,
And let's say you are a young new attending who's starting to transport on a guy who maybe in hindsight wasn't the perfect candidate, and you do your osteotomy or you do your corticotomy and you start transporting, and then they decide they want to stop. You can't exactly stop. You need that osteotomy to heal so that you can amputate at the right level. Otherwise, you're amputating through regenerate and you're usually up in the proximal metaphysis. There's a lot of things to think about. So it's nice to have a plan before you start. Sorry for that digression.
no,
But
no, it's perfect.
amputation is definitely an option that is improving every year, just like the technology we use to restore limbs. So I don't really remember where we were going with that, but
No, we're just talking about amputation as being kind of another option
one of
for
the
these
one of the
patients.
happiest guys that I've ever treated is a guy who cut his transport short. He was a new retiree, chronic osteomyelitis for 45 years in his right leg, and he was a limo driver. It was amazing with a draining sinus. Probably like a 50-degree valgus deformity and like 30 degrees external rotation through the center of his tibia. It was
Yeah.
wild. And he drove on that leg. But
Wow.
once he retired, he wanted it fixed. So we fixed it, right? We took out the infection. We got him infection free, started transporting him. And then halfway through, he said, listen, this ain't my retirement. You got to stop. So I took his leg and I acutely shortened it just to just to try to get it to heal. I couldn't get his docking site to heal. And we revised it twice, 2 non-union repairs, couldn't get it to heal. And then he said, just take the foot off. We amputated him. He fits the socket beautifully, and he's the happiest guy. He's actually still driving, right leg.
Yeah. Wow.
So he's the happiest guy I have. So it's definitely not a failure. For some people, it is definitely a freeing thing.
Yeah,
I know what
no,
you think. You're
totally
like, yeah,
agree.
man, you had him in a cage for 8 months. Of course, he's happy to.
Right. No,
Yeah.
no, that's great. That's great. Dr. Frumberg, I think this has been great. I mean, we talked about a whole bunch of stuff. We talked about what bone defects were. We talked about kind of some of the different way or the classification of how to think of things. We talked about bone defects, soft tissue defects, the type of host that it should be. Then we talked about different treatment options. We talked about shortening, grafting. We talked about Masquelet. We talked about some of these kind of distraction-based techniques, amputation. I feel like we covered a lot in this podcast. Anything else you want the people to know listening to this podcast about kind of limb lengthening or anything that we may have missed?
Yeah. If it's really been fun to talk about it, and I can't believe we stuck to time. So if you're still listening this far and this stuff was cool, the Limb Lengthening Reconstruction Society is a small subspecialty group that is an AAOS approved group. I mean, we're a really fun, approachable group of surgeons that like to do all this crazy stuff. And if you're interested in that, we do tons of teaching. We have a great annual meeting every year. Go to the website, llrs.org. And, if there's anything I could do for you guys, let me know. Feel free to reach out. And yeah, it's been fun. I mean, hopefully when you see these bone defects in practice, you don't write these patients off and you know that they have options. And there's a lot you could do to help them save their limbs if that's what they want.
Yeah, awesome. I love it. That was a great way to end it. And again, thank you so much for being a guest on the podcast. We'll put the link to all those websites here in the description if you want to go and take a look at it. Hopefully this inspires at least a couple people, at least one person to, be the next, limb lengthening person or pique their interest. I really thought those were interesting cases. I won't be doing many limb lengthening things, but I will be taking some thoughts or some the ways that you do certain things for some of my cases, my osteotomy cases per se. Again, but thank you so much for being a guest on the podcast. Those that are listening, thank y'all for listening. We hope that you enjoyed it. We hope that you go and leave us a review. Let us know how much you enjoyed this episode. And again, thanks for being a guest on the podcast.
Thank you.